Welcome back to the Deep Dive. Today we are shifting gears a little bit. We're not just casually browsing a topic, we're actually entering exam mode.
Right, full focus.
Specifically, we're looking at a scenario that strikes fear into the heart of many postgraduate students: the anesthetic management of patients with cirrhosis of liver and liver transplantation.
Oh, it's a massive topic.
Right.
And frankly, it is an absolute favorite of examiners for a reason.
Why is that?
Because it tests everything. I mean, everything. It tests your physiology, your pharmacology, your understanding of critical care, and your ability to manage, these incredibly high-stakes hemodynamics.
Exactly. So for the next hour or so, I want you to imagine you are sitting right there across from the examiner at Gujarat University. I'll be the student, probably sweating a little bit, and you're the senior MD anesthesia faculty.
Okay.
Our listener is right there with us, preparing to answer that dreaded 20-mark theory question, or trying to navigate a really rigorous viva.
That's the mission, then. We're going to take a whole stack of sources: Miller, Harrison, Stolting, the core texts, and just distill them. We'll turn them into a structured, high-yield audio overview.
Perfect.
But, and this is important, we aren't just reciting facts. If you just recite facts in a viva, you might pass, but you won't excel.
You won't stand out.
No. We need to build an answer structure that shows you understand the why, the physiology behind the chaos.
Let's start with that context then. Why is this such a huge topic? I mean, obviously liver disease is common, but is it really that critical for an anesthesiologist?
It is completely unavoidable. If you just look at the epidemiology in Miller, cirrhosis is the 9th leading cause of death in the U.S. The numbers are staggering globally.
And for us in the operating theater?
For us, the burden is distinct. You have patients coming in for liver surgery, sure, but you also have cirrhotic patients coming in for, hernia repairs, for cholecystectomies, for orthopedic fixes. They're everywhere.
And they aren't just normal patients who happen to have a bad liver.
Not at all, no. They are walking physiological time bombs. Cirrhosis is a multi-system disease. It involves irreversible fibrosis and this complete architectural distortion of the liver, which then creates a cascade of failure.
A cascade.
Yeah, in the heart, lungs, kidneys, the brain. So your perioperative risk is just sky high.
And the ultimate fix, the only definitive treatment, is the transplant.
Correct. As Harrison and all the major texts note, for end-stage liver disease, transplantation is the only curative option.
So the exam topic really splits into two worlds, doesn't it?
It does. World 1, managing the patient with a bad liver for some other non-transplant surgery, and World 2, the transplant itself, which is arguably the most complex procedure in all of abdominal surgery.
Okay, let's structure this answer then. If I'm sitting there holding the pen in the exam hall, where do I even begin?
You start with the absolute basics. Section 1, cirrhosis definition and etiology. This sounds basic, I know, but I see students mess this up all the time.
How can you mess up a definition?
By being vague. By just saying scarring of the liver. That's not good enough.
Okay.
You want the proper pathology definition, the one you'd find in Robbins. Cirrhosis is defined by 3 key features. 1, involvement of most or all of the liver. It's a diffuse process.
Okay, so not just a spot here or there, the entire organ is affected.
Exactly. 2, the presence of bridging fibrous septa. These are walls of scar tissue. And 3, the formation of parenchymal nodules.
Parenchymal nodules. I've always just memorized that phrase, but what does it actually mean physiologically?
Okay, think about the liver trying to heal itself. The hepatocytes are damaged, so the body tries to regenerate them.
Right.
But they're trapped inside these little cages of scar tissue, those fibrous septa we just mentioned. So they form these little islands or nodules of regenerating cells completely surrounded by scar.
Ah, so that destroys the architecture.
Completely. The blood can't flow through properly anymore. The whole system is broken.
That makes so much more sense. It's like rebuilding a house but blocking all the hallways with concrete. What about the etiology? If I'm making a list for the exam, what needs to go on it?
You need to categorize them. It shows you're organized. Miller and Harrison break it down really well. First, you have alcoholic liver disease. In Western countries, this is the big one.
Right.
Alcohol. Then, and this is crucial for our region here in the Asia Pacific, you have chronic viral hepatitis, hepatitis B and C.
Alcohol and viral hepatitis, the two giants. What's next on the list?
Non-alcoholic steatohepatitis, or NEET-SS, and this one is the rising tide. As obesity and metabolic syndrome just explode, we are seeing so much more fatty liver progressing to cirrhosis. It's a huge, huge epidemic.
Okay, so lifestyle factors are a major cause now.
Then you move to the metabolic and genetic causes. These are great for a viva because they can ask you about specific pathology,
Like what?
Hemochromatosis, that's iron overload, Wilson's disease copper overload, alpha-1 antitrypsin deficiency.
I remember seeing cystic fibrosis on that list too, is that right?
Yes, absolutely. And don't forget the biliary causes, basically problems with the plumbing. So that's primary biliary cirrhosis, PDC, and primary sclerosing cholangitis, PSC. And finally, a real Viva favorite, cardiac cirrhosis.
That's when heart failure causes liver failure.
Exactly. Chronic right heart failure causes this back pressure into the hepatic veins. The liver just gets congested with blood, it gets swollen, and eventually it becomes fibrosed. It's a two-way street between the heart and the liver.
Okay, so we've covered the what and the causes. Now we need to get into the how, the pathophysiology. This is where the examiner is really listening, isn't it? This is the meat of the answer.
Absolutely. 100%. If you don't understand the pathophysiology, you cannot possibly manage the anesthesia. The central concept, the sun around which everything else orbits, is portal hypertension.
Let's define that first, clearly.
Normally, the pressure difference, the gradient between the portal vein and the hepatic vein is tiny, maybe 2 to 3 millimeters of mercury. Blood just flows through the liver easily. But in cirrhosis, that gradient rises. Portal hypertension is clinically defined as a hepatic venous pressure gradient, or HVBG, greater than 5 mmHg.
But, I mean, 5 mmHg doesn't sound like very much pressure.
It's the threshold. It's where things start to go wrong physiologically, but clinically, the real trouble starts at 10 mmHg.
And what happens at 10?
That's when varices start to form, and at 12 mmHg, they bleed.
Okay, so why does the pressure go up in the first place? Is it just a clog in the pipe?
It's a mix of a clog and a flood. So first, the clog. This is the mechanical resistance. And to understand this, you have to visualize something called the space of Dissy.
The space of Dissy. I remember that from first-year histology, but you'll have to remind me what it actually does.
Okay, so picture the liver cells, the hepatocytes, on one side,
Right.
and the blood vessel, the sinusoid, on the other. Between them is this tiny, tiny space. That's the space of Dissy. Normally, it's a delicate open area where plasma can just freely wash over the liver cells for metabolic exchange.
Like a loading dock for the liver cell.
Exactly like a loading dock. But in the space of Dissy, there are these special cells called hepatic stellate cells. Normally, they're just quiet. They store vitamin A.
Right. Okay.
But in cirrhosis, they get activated, they get angry, they transform into myofibroblasts.
Which means muscle fiber builders.
Yes. They start laying down thick collagen scar tissue right there in the loading dock. They turn that permeable mesh into a brick wall. This process is called capillarization of the sinusoids.
So the windows of the factory close up.
Precisely. The fenestrations close, and this physically blocks the blood flow. That's your mechanical resistance.
So the road is blocked. But you said there was a dynamic part too.
Yes. And this is where the pharmacology really comes in. The resistance isn't just from the scar tissue, it's also from vascular tone.
And this involves the nitric oxide paradox, doesn't it? I remember reading about this.
It does. This is the classic tale of two circulations. Inside the liver, the endothelial cells are damaged. They don't produce enough nitric oxide, or NO.
And NO is a vasodilator.
Right, so the lack of it means the blood vessels inside the liver constrict. They clamp down.
So the liver itself is tight and clamped down.
Correct. But, and this is the absolutely crucial part for the anesthesiologist, look downstream at the splanchnic circulation, the gut.
What's happening there?
It's the Wild West. You have portal hypertension causing edema in the gut wall. This allows bacteria from the gut, or just their endotoxins, to translocate into the portal bloodstream.
What people call leaky gut.
Right. This constant low-grade shower of endotoxins triggers a massive inflammatory response. The body releases cytokines like TNF-alpha, and these cytokines tell the blood vessels in the gut to produce enormous amounts of nitric oxide.
Whoa! So inside the liver, no nitric oxide, and the vessels are constricted.
Yeah.
But outside the liver, in the gut, there's too much nitric oxide, and the vessels are wide open.
Perfectly put. This massive splanchnic vasodilation is the root of almost all the problems in cirrhosis. It leads directly to the hyperdynamic circulation.
You explain that.
Because the gut vessels are so massively dilated, they hold a huge amount of the body's blood. The systemic vascular resistance, the SVR, drops through the floor.
And to compensate for that, the heart has to pump much harder.
Exactly. The cardiac output has to increase dramatically just to fill that massively dilated vascular bed and maintain blood pressure. So you have a patient who looks warm, well-perfused, with a bounding pulse.
But they're not okay.
No, their physiology is incredibly fragile. They are basically running a marathon just to stand still.
And all the while, the liver isn't doing its actual day job.
Right. You get synthetic dysfunction. It stops making albumin, so oncotic pressure drops, and fluid leaks out into the belly, causing ascites. It stops making clotting factors, leading to coagulopathy, and it stops clearing toxins.
Which leads us directly into the systemic effects. You called this exam gold, didn't you?
It is. If you get a question on the systemic effects of cirrhosis, you need to be very systematic. Go organ by organ.
Okay, where do we start?
Start with cardiovascular. We just mentioned hyperdynamic state, but you must mention cirrhotic cardiomyopathy.
That sounds like a contradiction. You just said the heart is pumping like crazy. How is it a cardiomyopathy?
That's the classic trap. It's a condition where the heart functions, apparently normally at rest. Remember, the low SVR makes it very easy for the heart to pump. It has almost no afterload to push against.
So it looks strong.
But under stress, like during surgery or a vessel clamp, or even just intubation, it completely decompensates.
It's a lazy heart.
Or a weak heart.
It's an exhausted heart. There is a blunted contractile response, and this is because of downregulation of the beta-adrenergic receptors.
Why does that happen?
The heart is constantly being bathed in sympathetic stimulation just to keep up that high cardiac output, so the receptors eventually just stop listening. They get desensitized.
So the key takeaway is, don't be fooled by the high cardiac output you see on the monitor. The reserve is gone. Precisely. Next up is respiratory. You have the obvious mechanical issues, massive ascites pushing the diaphragm up. This causes a restrictive pattern, it causes atelectasis, and it reduces the functional residual capacity, the FRC.
Which makes intubation and ventilation much harder.
It does. But for the exam, you need to go deeper. You need to talk about the two vascular issues, hepatopulmonary syndrome, or HPS, and portopulmonary hypertension, or PoPH.
These two always get confused. How do we distinguish them cleanly for the examiner?
Think about the vessel itself. Hepatopulmonary syndrome is all about dilation. You have intrapulmonary vascular dilation.
Okay, dilation.
Normally, red blood cells march single file past the alveoli to pick up oxygen. In HPS, the vessels at the base of the lung are blown wide open. The blood just rushes through the center of that wide stream without ever touching the wall to get oxygenated. It's a shunt.
Is that where the classic triad for diagnosis comes in?
Yes. The triad for HPS is 1. Liver disease, 2. An increased alveolar arterial gradient greater than 15 mmHg on room air, and 3. Evidence of intrapulmonary vascular dilation.
And clinically?
Clinically, you look for platypnea, which is shortness of breath when sitting up, and orthodeoxia, which is desaturation when sitting up.
Because gravity pulls more blood to those dilated vessels at the base of the lung when they sit up.
Exactly. It worsens the shunt. Now, contrast all of that with portopulmonary hypertension. This is about constriction and obstruction.
So the complete opposite problem.
Yes. It is pulmonary arterial hypertension that occurs in the setting of portal hypertension. The pulmonary vessels clamp down and remodel. It's defined as a mean pulmonary artery pressure greater than 25 mmHg and a pulmonary vascular resistance greater than 240 dynes.
Okay, so to summarize, HPS is vasodilation, which causes hypoxia. PPH is vasoconstriction, which causes right heart strain.
Perfect. And that PoPH is a major contraindication for a liver transplant if it's severe, because the right heart will fail immediately when that new liver is put in and cardiac output surges.
Moving on to the renal system, we have Hyperrenal syndrome, or HRS. This is one of the things I find really hard to explain clearly. Is the kidney actually failing?
No, and that's the key point. The kidney is structurally normal. You could take a kidney from a patient who died of HRS, transplant it into someone else, and it would work perfectly.
So why does it stop working in the cirrhotic patient?
Go back to that splanchnic vasodilation. The gut is holding so much of the blood volume that the central blood volume, the blood effectively circulating to the brain and kidneys, is very low. The body perceives this as central hypovolemia.
It thinks it's bleeding to death.
It thinks it's bleeding to death, and it screams for help. It activates the renin-angiotensin-aldosterone system, RAAS, and the sympathetic nervous system. These systems clamp down on all the vessels to try and raise blood pressure.
And the renal arteries get caught in that crossfire.
They get strangled. The kidneys are strangled by the body's own attempt to maintain blood pressure. The renal arteries constrict so severely that the GFR plummets, and you get oliguria and azotemia. It's a functional failure.
That is a terrifying cascade. Okay, what about hematology? We always think of these patients as bleeders.
Yes, and Miller has a great term for this, rebalanced hemostasis. It's more complicated than just bleeding.
Okay.
Yes, they have fewer procoagulants, factors 2, 7, 9s, and X because the sick liver can't make them, so the INR goes up. But And this is the key insight. They also have fewer anticoagulants.
Like protein C and protein S.
Exactly. The liver makes those too. So the entire balance is just reset at a lower, much more fragile level. They can clot and they can bleed. Their window of stability is tiny.
So you can't just assume they're auto-anticoagulated because of the high INR.
Never, ever assume that. They can absolutely still get a PE or a DVT.
Okay, and finally the CNS.
Hepatic encephalopathy. And the villain here is ammonia. Normally, the liver converts ammonia, which comes from protein breakdown in the gut, into urea, which is then excreted.
Right.
In cirrhosis, the liver can't do that metabolic conversion. And anyway, the blood is shunting around the liver through varices. So the ammonia goes straight to the systemic circulation and crosses the blood-brain barrier.
What does it do to the brain?
It primarily affects the astrocytes. It causes cerebral edema and fundamentally alters neurotransmission. This can range from just mild confusion, or what we call grade 1, all the way to a deep coma, which is grade 4.
Okay, we have covered the pathology in a lot of detail. Now let's simulate the case. The patient is in front of us in the pre-op clinic. We need to do the preoperative risk stratification. What scoring systems are mandatory to mention in the exam?
You must know the Child-Pugh score, the CTP score, and the MELD score. You cannot walk into that exam without having these memorized cold.
Let's break down the CTP score. I have a mnemonic I use. Pour another beer at 11.
It's the classic one, and it works perfectly. Pour is for prothrombin time, or INR. Another is for albumin. Beer is for bilirubin. At is for ascites. And 11 is for encephalopathy.
And you score each of those from 1 to 3 points.
Yes. And based on the total score, you classify them. Class A is 5 to 6 points. That's low risk. Perioperative mortality is roughly 10%.
Okay.
Class B is 7 to 9 points. That's moderate risk. The mortality jumps to around 30%.
And Class C?
Class C is 10 to 15 points. This is very high risk. The mortality for a major open surgery can be over 80%. Generally, you do not electively operate on a child C patient unless it is a life-saving emergency or, of course, a transplant.
And MELD, that's the model for end-stage liver disease.
Right. And MELD is, statistically a bit more robust. It was originally designed to predict 3-month mortality for patients awaiting transplant. It uses 3 objective lab values: bilirubin, INR, and creatinine.
Objective is good. Child-Pugh has ascites and encephalopathy, which are a bit subjective, right?
Exactly. MELD takes the guesswork out. A MELD score below 10 is considered low risk. Above 15, the risk really starts to spike, and above 20, you are in very dangerous territory.
And newer versions have added sodium, right? MELD didn't
Yes,
have.
because hyponatremia is such a strong independent predictor of mortality in these patients.
Why is their sodium so low?
It's because of high ADH levels. The body's perceived hypovolemia triggers ADH release, which makes the kidneys retain free water, and that dilutes the sodium.
I see. Okay, so we've scored the patient. Now we need to evaluate them. What's on our pre-op checklist?
Well, the labs are pretty standard: LFTs, coags, electrolytes. But you have to be very careful with creatinine.
Why is that?
Creatinine comes from muscle breakdown. Cirrhotic patients are often sarcopenic. They have severe muscle wasting, so their baseline creatinine production is very low.
So a normal number might be hiding a problem.
A huge problem. A normal creatinine of 1.0 in a cirrhotic patient might actually mask significant renal impairment. Their GFR could be terrible.
That's a really good clinical pearl. A Viva trap. Don't trust the creatinine blindly. What about the heart?
A dobutamine stress echocardiogram is often mandatory, especially for transplant evaluation. These patients cannot run on a treadmill to stress their heart. You need to pharmacologically stress it to unmask that cirrhotic cardiomyopathy we talked about. You have to know if the heart can handle the stress of surgery.
I would say
You must assess the volume, and critically, you have to check for infection. Spontaneous bacterial peritonitis, SBP, is a killer. If they have SBP, you cancel the elective surgery and treat the infection.
okay, we are now moving into the operating theater.
Yeah.
We need to set our anesthetic goals. What are they?
I think of it as 4 pillars. 1, maintain hepatic perfusion. 2, avoid hypotension at all costs. 3, minimize blood loss. And 4, avoid worsening their encephalopathy.
Let's unpack that first one. Maintain hepatic perfusion. There's a specific reflex we need to talk about here, the HAVR.
The hepatic arterial buffer response, this is just brilliant physiology. The liver has a dual blood supply.
Yeah.
The portal vein brings about 75% of the blood, but it's oxygen poor. The hepatic artery brings the other 25%, but it's very oxygen-rich.
Okay.
If the portal vein flow drops, say, due to hypotension or surgical compression, adenosine accumulates on the liver, this adenosine causes the hepatic artery to dilate. It buffers the loss of flow to try and keep the oxygen supply constant.
And our anesthetic agents can mess this reflex up.
They can. The volatile anesthetics in particular tend to impair this response. They are dose-dependent vasodilators, but they can uncouple this vital reflex.
And IV agents.
IV agents like propofol tend to preserve it much better.
So let's talk intraoperative management. Induction. This has to be a full stomach situation, right?
Always. Always assume a full stomach in a patient with significant ascites. The high intra-abdominal pressure and gastroparesis delay gastric emptying. So rapid sequence induction, RSI, is the standard of care.
What agents are we using for that?
Propofol is generally safe. It has no adverse effect on liver function itself, but the patient might be very sensitive to the hypotension because they are centrally volume depleted. You have to titrate it very, very carefully.
What about thiopental? I've heard we should reduce the dose.
Yes, you must. Thiopental is highly protein-bound. About 80% of it binds to albumin. In cirrhosis, you have hypoalbuminemia.
Less albumin to bind the drug.
Right. So there's less protein to sponge up the drug, which means you have a much higher free fraction of the active drug hitting the brain.
So a normal dose acts like an overdose.
Exactly. You have to reduce the dose significantly.
Okay, now for maintenance, the classic debate. Volatiles versus Cyphi.
While halothane is history, halothane hepatitis is an immune-mediated necrosis. It's largely irrelevant now, but still in the textbook, so you should know about it.
And the modern agents.
Isoflurane, sevoflurane, and desflurane are much better. In general, sevoflurane and desflurane are preferred because they have the most favorable hepatic blood flow profiles. They cause the least reduction in hepatic arterial flow.
What about painkillers? Opioids.
This is where you can really hurt the patient postoperatively. The liver metabolizes most opioids. Morphine is a really bad idea.
Okay.
Its active metabolite, morphine 6-glucuronide, accumulates, and the elimination half-life of morphine itself can double or even triple. You'll end up with a patient who simply won't wake up.
And meperidine or pethidine?
Pethidine is absolutely contraindicated. It breaks down into normoperidine, which is neurotoxic and causes seizures. The cirrhotic liver cannot clear it at all.
So what do we use? What's the safe choice?
For major cases, especially a transplant, remifentanil is the ideal choice, the gold standard.
Why is it the MVP here?
Because of its metabolism. It is broken down by nonspecific plasma and tissue esterases. It doesn't need the liver. It doesn't need the kidney. You turn the infusion off, and 5 to 10 minutes later, the drug is gone. It gives you incredible control in a very chaotic environment.
And for smaller cases.
Fentanyl is also acceptable in smaller, titrated doses as its pharmacokinetics are fairly stable in early to moderate liver disease.
And muscle relaxants. This is a definitive exam question.
The gold standard answer, the one you must say, is Cisatracurium.
Again, why? What's the mechanism?
Hoffman elimination. It breaks down spontaneously in the plasma, dependent only on pH and temperature. It completely bypasses the liver and the kidney. It's organ independent.
And the others, like rocuronium.
Rocuronium and vecuronium are primarily eliminated by the liver and excreted in the bile. If you use them in a patient with severe liver failure, their duration of action will be significantly prolonged.
But if we do use rocuronium, say for the RSI, we have an escape hatch now, don't we?
We do, and this is a very common Viva question. How do you reverse rocuronium in liver failure? The confident correct answer is Sugammadex.
And how does that work?
Sugammadex works by encapsulating the rocuronium molecule directly in the plasma. The complex is then excreted by the kidneys. It's safe and highly effective in liver disease.
Okay, let's talk fluids and coagulation. We've established that the INR is unreliable. So how do we monitor their clotting status?
We have to move beyond the INR. I can't stress this enough. The INR was designed for monitoring warfarin, not for liver failure. It only measures some of the procoagulants. It completely misses the lack of protein C and S.
So what's the better tool?
Viscoelastic testing. That means TAG, or thromboelastography, or its cousin ROTEM. This gives you a visual real-time picture of the entire clotting process. Reaction time, clot strength, fibrinolysis.
So it tells you exactly what to give.
Precisely. If the R time is long, you give FFP. If the clot strength, the MA, is low, you give platelets, or, more likely, fibrinogen from cryoprecipitate. It prevents you from blindly transfusing products that might just cause volume overload and worsen chordal hypertension.
Speaking of volume, for a non-transplant surgery, we generally want to keep them on the dry side.
For non-transplant hepatic surgery, yes. A wet liver, a congested liver, bleeds much more. A high CVP distends the hepatic veins and increases back bleeding during dissection. The goal is to keep the CVP at low normal and use vasopressors to maintain perfusion pressure if needed.
All right. We have successfully managed the cirrhotic patient for a hernia repair. Now let's go to the main event. Liver transplantation. This is the physiological roller coaster.
This is the absolute peak of the specialty. The indications, as we said, are end-stage liver disease from alcohol or Hep C, hepatocellular carcinoma within the Milan criteria, and various metabolic diseases.
The exam will definitely ask about the phases of the surgery. There are 3 of them, right?
Yes, and you need to know the name and the distinct physiology of each one. They are the pre-anhepatic phase, the anhepatic phase, and the neohepatic phase.
Let's walk through them one by one. Phase 1, pre-anhepatic. This is the dissection phase.
Right. The surgeons are mobilizing the diseased native liver. You have to remember, this patient has severe portal hypertension. The abdomen is filled with massive, high-pressure collateral vessels.
Various everywhere.
Everywhere. And the surgeons have to dissect and cut through them. Bleeding is the main enemy in this phase. You can lose liters and liters of blood just getting to the liver.
And they're draining the ascites at the same time.
Yes, which can be 10 or 15 liters. Draining it rapidly drops the intra-abdominal pressure and can cause massive hemodynamic shifts. You need to be incredibly aggressive with fluid and blood product replacement just to keep up. You are constantly chasing the patient's tail.
Then comes phase 2, anhepatic. They clamp the major vessels and take the old liver out.
This is a massive, massive physiological shock to the system. They clamp the inferior vena cava and the portal vein. Just think about the anatomy for a second. You have just cut off all venous return from the lower half of the body and the entire gut.
So a preload just crashes.
It plummets. Cardiac output can drop by up to 50% the second those clamps go on. The systemic vascular resistance might jump up initially as a reflex, but the patient is essentially in profound obstructive shock.
And what's happening metabolically?
It's pure chaos. There is no liver function at all.
So what happens?
Lactate rises because there's no organ to clear it. You get severe hypoglycemia because there's no gluconeogenesis. You need to be monitoring their sugar very closely. But the big one, the one that can kill them, is citrate toxicity.
Explain that concept.
You are likely pouring in blood products at this point. All those blood products contain citrate as a preservative to prevent clotting in the bag. Normally, a healthy liver metabolizes that citrate almost instantly.
But there is no liver.
Exactly. Without a liver, the citrate accumulates in the bloodstream.
And citrate binds to calcium.
It chelates ionized calcium very eagerly, so you get severe, profound hypocalcemia. And calcium is vital for cardiac contractility and for vascular tone. If you miss this, the heart weakens and the blood pressure completely collapses. You must have an ionized calcium monitor and be pushing calcium chloride regularly.
What about potassium?
You tend to get hyperkalemia, which is driven by the acidosis, and a lack of cellular uptake. It is a complete metabolic storm.
Sometimes the surgeons use a bypass during this phase, right?
Yes, veno-venous bypass. They'll cannulate the femoral vein and the portal vein, run that blood through an external pump, and return it to the axillary or jugular vein.
And what does that do?
It maintains venous return to the heart and prevents congestion of the gut. It makes the hemodynamics much, much smoother, but it does add its own complexity and risk of cooling the patient.
Then comes the moment of truth. Phase 3, Neohepatic, the reperfusion.
This is, without a doubt, the most dangerous few minutes of the entire operation. This is reperfusion syndrome.
I want to slow down here. This is the ultimate exam favorite. What exactly is happening when they unclamp?
Okay, picture the scene. The surgeons have just finished sewing in the new donor liver. The clamps are still on. The patient has been without a liver for maybe 60 to 90 minutes. They are cold, they are acidotic, and their calcium is probably low despite your best efforts. The surgeon looks up at you over the drape and says, "Ready to unclamp?"
And you have to be ready.
You have to be more than ready. You have to anticipate, because the second they release that portal clamp, blood from the portal vein rushes through the new liver for the first time and then straight into the heart. But what is in that new liver?
It's been on ice. It's cold.
It's been sitting in preservation solution, usually University of Wisconsin solution, which has a very high potassium concentration. It's full of cold acidotic metabolites that have built up, and it is full of vasoactive inflammatory cytokines that have accumulated during the ischemic period.
I've heard it called the bolus of death.
That's a dramatic, but honestly a pretty accurate way to put it. This washout of cold, hyperkalemic, acidotic, cytokine-rich blood hits the right heart instantly.
What are the diagnostic criteria for reperfusion syndrome?
It is classically defined as a decrease in the mean arterial pressure of more than 30% immediately following unclomping, lasting for at least 1 minute. But it's much more than just hypotension.
What causes that profound crash?
It's a combination of 3 things. First, vasodilation. The cytokines cause this systemic vascular resistance to just collapse. Second, myocardial depression. The cold, acidotic blood directly stuns the heart muscle. Yeah. And third, arrhythmias. That bolus of potassium can cause severe bradycardia or even a systole.
So the heart can actually stop.
It absolutely can. I've seen it happen. It is terrifying.
So how do we manage this? How do we prevent the arrest?
Anticipation. It is all about anticipation. Before they unclamp, you volume load the patient, get the CVP up to fill the tank for the vasodilation. You aggressively correct the acidosis with bicarbonate, and you correct the calcium. Okay. Give a good bolus of calcium chloride just before they unclamp.
And what about pressors?
You have your vasopressors, usually epinephrine or norepinephrine drawn up, in a syringe connected to the line with your hand on the plunger. Some anesthesiologists will even start a very low dose infusion of epinephrine before the clamp comes off.
You're treating the future.
Exactly. You are catching the falling knife before it even hits the floor.
Once the blood is slowing again, how do we know if the new liver is actually working?
We look for signs of early graft function, and there are a few. One, the surgeons might see golden bile production. That is a fantastic sign. On your ABG, you see the clearance of lactate. The acidosis starts to resolve on its own. Third, you see normalization of the coagulopathy. The INR starts to drop without you giving any more FFP. And fourth, the glucose levels start to stabilize as the new liver begins gluconeogenesis.
And if those things don't happen?
Then you start to worry. You worry about primary graft dysfunction, the liver just isn't waking up. Or you worry about a technical problem, like vascular thrombosis.
Hepatic artery thrombosis.
That is the absolute nightmare scenario. The biliary tree, the bile ducts, rely solely on the hepatic artery for their blood supply. If that artery clots, the bile ducts die. It's called biliary necrosis. A Doppler ultrasound is mandatory immediately post-op to confirm that you have pulsatile arterial flow.
Let's zoom out for a second. A really common exam question is to ask you to compare anesthesia for cirrhosis surgery versus anesthesia for a liver transplant.
Yeah.
How do you frame that comparison for the examiner?
I think it's a difference in philosophy. You can draw a table in your mind.
Okay.
In column A, you have cirrhosis surgery, like a hernia repair. The goal here is preservation. You want to preserve the little liver function they have left. You are gentle. You avoid hypotension to prevent HRS. You are very cautious with your fluids, a restrictive strategy to prevent variceal bleeding and worsening ascites. You want to extubate them early if you can.
And column B?
Column B is the transplant. The goal here is replacement. You are managing massive, predictable physiologic swings. You aren't preserving anything, you are replacing the entire organ. You anticipate massive fluid shifts. You are liberal with fluids during the pre-Anhepatic phase to keep up with bleeding. You are aggressive with vasopressors, and you fully expect them to be ventilated post-op.
That's a great mental model. Preservation versus replacement. Now, before we wrap up, let's hit some of those Viva traps. These are the questions that examiners love to ask to trip you up.
Okay, trap number 1. Why is your cirrhotic patient hypoxic?
And the bad answer is?
The student says pneumonia or ascites pushing on the lungs. The examiner looks bored.
What's the answer?
The good answer is, I would first need to differentiate between hepatopulmonary syndrome, which is a problem of vasodilation and shunt, and portopulmonary hypertension, which is a problem of vasoconstriction and high pulmonary pressures. You must demonstrate that you know the underlying vascular pathology.
Trap number 2.
How do you reverse rocuronium in a patient with total liver failure?
The student might hesitate.
Yes, because they know rocuronium is liver eliminated. They might suggest neostigmin, which would be very messy. The confident answer is Sugamedix. It is renally excreted and encapsulates the drug independent of liver function.
Trap number 3.
Is the coagulopathic cirrhotic patient auto-anticoagulated? The student looks at the chart, sees an INR of 2.5, and says, yes, they are safe from clots.
And the examiner says fail.
Exactly. The answer is no. Because of the concomitant drop in protein CNS, the natural anticoagulants, they are actually in a rebalanced and sometimes prothrombotic state. Despite the high INR, they remain at high risk for PE and DVT.
That's a crucial distinction, the rebalanced hemostasis.
One more specific exam favorite. What is the specific electrolyte disturbance you expect to see in the Anhepatic phase? If you just say, electrolyte imbalance, you get 0 marks.
Just be specific.
You must say, profound hypocalcemia due to citrate toxicity from blood transfusion and progressive hyperkalemia due to acidosis and cellular release. If you miss those, you miss the entire management of the potential arrest on reperfusion.
Okay, we have covered a ton of ground, from the space of DISI all the way to the reperfusion bolus. Expert, if you had to summarize this for the student walking into the exam hall right now, give me the 20-second elevator pitch, the absolute key takeaways.
Okay, rapid-fire recap.
Pathology, it's all about portal hypertension, causing splanchnic vasodilation.
Circulation. It's hyperdynamic but incredibly fragile. Cirrhotic cardiomyopathy masks the real risk.
Lungs, HPS is a shunt, causing hypoxia. PoPHT is high pressure, causing RV failure.
Scoring. No Child-Pugh and MELD cold.
Drugs, remifentanil because of esterases and Cisatracurium because of Hoffman elimination are your safety nets.
Transplant. You have to watch out for the Anhepatic metabolic crash, specifically low calcium, high potassium.
Reperfusion. Anticipate the washout. Have your pressors and calcium ready before the clamp comes off.
Monitoring. TEG or ROTEM beats the INR every single time for guiding therapy.
Fantastic. To our listener, I really hope you were taking notes or at least visualizing that liver architecture changing. Remember the space of DISI turning into a brick wall. Remember the concept of the starving liver and the bloated gut.
And just remember, these patients are fragile. They look stable until the moment they aren't. Your job as the anesthesiologist is to be paranoid. Anticipate the decompensation before it happens.
Thanks for joining us on this deep dive. Good luck with the exam. You've got this.
Good luck. Go study that reperfusion flowchart.
We'll see you next time.